Good morning, everyone. I hope everyone enjoyed session one. On the behalf of the American Heart Association, I am Aliza Rizvi, Senior Program Manager at the American Heart Association and your second co-host for this forum. I would like to welcome you to this session, introducing the American Heart Association's Beyond Pregnancy Recommendation and Resources Toolkit. This session will introduce the American Heart Association's Beyond Pregnancy Recommendations Toolkit and highlight the Advancing Maternal Health Initiative, which really focuses on enhancing postpartum systems of care as it relates to cardiovascular disease. Throughout this session, you will have the opportunity to submit your questions to our speaker using the questions feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A towards the end of today's session as time allows. To access live closed captions, please click on the closed caption button found on your screen. As a reminder, all sessions will be recorded and available in the coming weeks. It is my pleasure to introduce and welcome our speaker for today's session, Dr. Rachel M. Bond. Dr. Bond is a board-certified cardiologist in Arizona and a nationally recognized leader in women's cardiovascular health and prevention. As a reminder, full speaker bios can be found in the event lobby. Dr. Bond, I'll pass it over to you.
Thank you so much for that warm introduction, and I'm looking forward to this session. So we're going to just get started. As Alize mentioned, I'm a cardiologist out in Arizona, and a lot of the work that I do is focused on maternal health and the intersection between cardiovascular disease and pregnancy, but really more importantly across that continuum. And when I was asked to be part of this initiative, I was so excited for it because when you think about where we are today in the United States, still, unfortunately, cardiac disease is one of the leading causes of death, preventable death, over 80% preventable when it comes to pregnancy-related deaths. And when we think about it in the United States, we know that there are so many disparities based on where one lives, be it lower income communities, rural communities, but also most pivotally, disparities based on our race and ethnicity. And we see that Black women and American Indian women often have the highest rates of very preventable maternal outcomes, with Black women dying at 2 to 3 times the rate of their white female counterparts. And when you think about pregnancy, for me as a cardiologist, I always often tell my patients that it is your maybe first, but definitely your most important physiological stress test that you're going to be undergoing. And oftentimes there are cardiac conditions that could be unmasked during that pregnancy. And what women don't always realize, as well as their physicians and clinicians, is that heart disease during pregnancy doesn't leave women with a higher risk that ends at pregnancy. It actually leaves women with a higher lifetime risk of cardiovascular disease after delivery. And that risk is furthermore increased for their children and their offspring. So that postpartum period, that day 1 to 365 day after their delivery, is actually the most pivotal. And why it's the most pivotal is because when you look statistically, two-thirds of the United States pregnancy-related deaths actually occur during that postpartum period. So often day 7 to 365. And a lot of that for me as a physician often makes sense. Why? Number one, the care of women become often less and less in the postpartum. It doesn't get, which implies that we don't always have that opportunity to catch earlier on any complications or any signs that may be putting us in a point to think that cardiac disease may be an actual issue for them. But another reason is that a lot of those cardiovascular conditions are often unmasked, more so in that postpartum window where hormone changes are happening, fluid shifts are happening. So this makes the postpartum period the most important. And that was really the focus of the initiative that we implemented. Really, the goal was to think about through this maternal cardiovascular crisis, how can we have a multidisciplinary approach to really focus on key areas but make the most impact? So our initiative was first started in July of 2022. The American Heart Association recruited a total of 9 writing group members, myself being one of them, and we came from very, very diverse backgrounds, as you'll see in the next coming slides. We then expanded to the next phase where we added 2 additional cohorts, really with the goal to take whatever recommendations we, as the writing group, suggested and actually implement them. The goal of implementation was really to focus on systems of care, education and training, evidence-based implementation, and how the community can be integrated into clinical practice. And again, the goal was impact, because the impact is most important. We were hoping that with all of our recommendations that there would be stronger maternal cardiovascular care, improved postpartum outcomes, and reduced care silos, because we know that it can't just be one specialty caring for women. Everyone has to get their hands involved. And as I mentioned, the writing group was very diverse. It included physicians like myself in cardiology and OBGYN and maternal fetal medicine, but it also included our midwifery colleagues, our nurse administrators, our doulas as well, incorporating that community into the mix. And when it came to nurses, they were spanning very different areas of healthcare, even emergency medicine, where they're often on the front lines. And many, many times it's the biggest opportunity where the emergency room can also dictate the care of what happens during the future hospitalization. So we wanted to definitely get their involvement as well and really have a very diverse collaborative. When it comes to that collaborative, as mentioned, the diverse working group was key, but we also wanted to ensure that the 15 clinical organizations were just as diverse. And they spanned hospitals and health centers, community organizations that had midwives and doulas, but also other community health workers, because our target were populations where having trusted members in the community really makes the biggest impact in terms of improving outcomes. We wanted to make sure that there was a geographical variation in terms of the sites. We also, of course, wanted to include maternal health deserts, because we know that oftentimes obstetric care there isn't as robust, but we really wanted to focus on equity and access. And the goal really was for these 15 clinical organizations to, through peer learning and model sharing, really help in the implementation of the recommendations that we as the writing group already put forth. As a result of that, there were site-specific objectives, and there were also objectives to ensure that there would be sustainability, because the goal wasn't just to check off a box, it was really to make sure that this was leading to postpartum improvement. And the way to lead to postpartum improvement, I would say, is really to incorporate the lived experiences of the collaborative. So voices of birthing people were so, so key. Ensuring that, again, there was that collaborative learning environment, that we were having diverse voices in the community that were also a part of the implementation, but we were also honing in on real world lived experiences and maternal health access gaps, because we know that there are often gaps that really make it challenging for any implementation of recommendations. This here is a map of all the participants, and I think it's a map that we should be proud of because it is very diverse, spanning across several areas of the United States. But of most significance, I would say, is that this map does mirror what we see when it comes to our maternal care deserts. And a lot of the mirroring has to do with the historical context of why we're seeing higher rates in certain areas of the United States. And that could go back as far as when we had enslaved people, as an example. And this map here really points that understanding our history really truly dictates even our future, but also our current, more importantly. So one can say that this was a very diverse realm across the United States, which is great. In the next coming slides, we're going to talk about the excitement of the toolkit that, since all these initiatives have been implemented, is now out. And that's the most exciting piece, which is that the toolkit is out now and it's ready for use. And the QRS code, if you have your cell phones handy, I would encourage you as I go through each and every recommendation to really log into the website because this gives you, as an individual, as an organization, really key ways to actually make an impact when it comes to overall maternal health. But we're going to do a deeper dive in it. When we as a working group first created this toolkit or had a thought to create the toolkit, we really wanted to focus on four areas: standardizing postpartum systems, having interdisciplinary care and engagement, having advocacy and policy expansion, because of course we know that in order to really get things done, we need to ensure that there's coverage for those things, and really having risk factor identification and monitoring. And then it sort of evolved into the expansion of all those four key areas where version 2, which again you have access to with that QRS code, is now readily available. We're going to go through each recommendation. So recommendation number 1 is talking about standardizing postpartum systems. And how do we do that? Well, the first thing is the goal was because oftentimes once a birthing person delivers a baby, many times those in healthcare, as well as the patient, believe that their work is done. But no, when we think about what actually defines a postpartum window, we know that it's also not that immediate postpartum window only, meaning the first 6 weeks of that postpartum period where you are still seeing your OBGYN team. But we as a group thought it would be very, very important and more importantly, critical to ensure that people are asking the question of when was the patient last pregnant? And when did they have their baby? And was it within a year of their delivery? In emphasizing the importance of that 1 year postpartum. We also talked a lot about how it's important to understand that women can develop elevated blood pressure and cardiovascular issues, not just during pregnancy, but also in that postpartum. Included in that is preeclampsia. As many of you on the call, I'm sure, are aware, there's a higher abundance nowadays of women having postpartum preeclampsia than antepartum or during pregnancy preeclampsia. Assessment and labs were also something that we really wanted to hone in on, and the American College of Obstetrics and Gynecology does a great job in standardizing some recommendations on what cardiometabolic labs should be looked at. I will say that these are systems that are very much supported by our cardiovascular medical societies, including the American Heart Association. But with the new implementation, we knew that in order to do this effectively, we have to support cardio-obstetrics training. And for those on the call who are not familiar with what that is, this is where a cardiologist and an OBGYN or a maternal fetal medicine expert work collaboratively together. There are actually now fellowships where they are allowing, as well as residencies, where they are allowing our OBGYN colleagues to rotate in cardiology, our cardiology colleagues to rotate with OBGYN. So as you learn from a different subspecialty, you have the ability to merge an amazing cardio-obstetric expert. With that, also, we have promoted and implemented pregnancy heart teams. So this is, again, where you have a very diverse group of clinicians and physicians that are part of the team. And it doesn't just mean it's OBGYN and cardiology. That also should include our internal medicine colleagues, our family medicine colleagues, our emergency medicine colleagues, and really any allied health professional who's going to impact women's health in any which way. It's really to enhance the clinician competencies in risk stratification, prevention, and long-term cardiovascular care. When we think about recommendation number 2, this is where interdisciplinary care and engagement was also something pivotal. And it wasn't just in the setting of different specialties, it was actually in the setting of how do we bring midwives, doulas, mental health practitioners, community health workers, and trusted community leaders into the discussion as well. That way we can focus on a more holistic way to manage these patients. One big way is to ensure that there is universal postpartum mental health screening. Now we know that mental health conditions remain also one of the leading causes of maternal mortality, and they do negatively impact one's future cardiovascular health as well. So how can we make it more universal to ensure that every patient, especially in that postpartum where stress levels may be at an all-time high, are getting that universal screening? Part of that really does include ensuring that postpartum care is not just addressing the physical, but also the mental and social needs of patients. This is where we should be routinely screening for social drivers of health, as an example, but having easy access to community referral pathways where if the clinician isn't able to have those discussions as openly and as vividly as we would like, utilizing our community healthcare workers to help in the mix should be sort of standard of practice. This is also where the partner and the chosen family engagement is so important as well, because we want to empower those that are supporting the birthing person to really be there. And this is where peer support groups, included for individuals that may not have identified partners, or peer groups that actually have partners or family that are very involved in their care, also should be standard of practice. One thing that was also pivotal in this mix was including nephrologists, and nephrologists are not necessarily the only specialists that one would consider to be added to the pregnancy heart team. And for those on the call who are not familiar, a nephrologist is a kidney expert, but it points to the picture that, again, maternal care has to be expanded beyond just OBGYNs, the team and members that are focusing on women's health, and even beyond the cardiologist, because it impacts every organ in one's body, and all of those organs impact their cardiovascular health. Recommendation number 3 was really set for advocacy and policy expansion, making sure every state in the United States expands to covering postpartum care up to 12 months after birth, particularly knowing that that's where the rates of death and complications are at its highest. So really emphasizing the importance of that. We also talked a lot about the role pediatricians may play. And when you think about it in society, many times birthing people are always willing to bring their child to the pediatrician. And as a result of that, they may not make every one of their postpartum visits because they're trying to manage and balance that very busy lifestyle. But what about if the pediatric clinician or physician actually has outpatient practices where they're also looped in with them, they're collaborating with internal medicine or family medicine, where as the mom is there, as the birthing person is there for their visit, they have the opportunity to get their blood pressure checked as well. And if their blood pressure was elevated, they then would be escalated into a realm where they would be able to get in with a healthcare clinician earlier, really again to ensure we focus on prevention. We also talked a little bit about obstetric health and clinicians, and that they should offer all birthing people the opportunity to participate in group-based care and peer mentoring. There are data to support that when people collaboratively are working together, they're more likely to ensure that there's that follow through and follow up. And that's such an important part, because we know we lose a lot of mothers in the postpartum, and we want to make sure that there's easy transitions of care, but we're also coming up with unique ways to ensure that that happens as well. And in that is reimbursement, because we know that right now, in order to ensure that we have full exposure to these patients, our goal really is to ensure that we meet them where they are. Sometimes that includes telehealth visits or telemedicine, where we do blood pressure checks remotely, but that's hard to do if it's not covered by healthcare insurance. So really, a policy expansion would be to ensure that there is reimbursement of rates for these unique ways that we can access patient care. Also, creating national databases for reporting quality performance measures, something that has to happen, and also providing standardized postpartum warning sign education. That way, everyone across the board understands what we should be educating our patients. And this is where our community health workers can help so much, because by educating them on those warning signs, they're going to educate the patients in the long run. The 4th recommendation was risk factor identification and monitoring. And as I mentioned, it's not only important to educate people on warning signs, it's also important for them to understand their risk factors, but also optimize those risks before pregnancy. So the most pivotal time is in that preconception and interconception or interpregnancy period. So this is where blood pressure, cholesterol, blood sugar levels, discussions on weight, discussions on exercise, discussions on nutrition. That is such a key factor because we do know that the vast majority of birthing people in the United States are not necessarily in the most ideal health. And as a result of that, the majority of them also don't have a high percentage of the time going for preconception counseling. So at any moment, we have a discussion with a patient, particularly a patient of reproductive age, it's really important that we focus on those risk factor, not just for monitoring purposes, but also management purposes as well. And there are gaps when you think about it in the literature about how individual health and cardiology and disparities of representation in research tie into this. I can tell you from a cardiovascular perspective that women in general, at best, are 30% included in research trials. And all of this translates into why we're seeing disparities and why cardiac disease is one of the leading causes of death for pregnancy, because we're just not studying women and birthing people as often as we should. But through several amazing initiatives through the American Heart Association and other medical societies, we are beginning to do so. Another action item, again, was the mental health screening, which is so key. And understanding that women with heart disease really should be evaluated before conception. That way, we as a team collectively can determine what medicines need to come off. Are there any additional testing that needs to be done? So these recommendations as a whole were so important, and they really talked a lot about the use of validated screening tools, screening at multiple touch points. Again, the prenatal being the most pertinent, but also the postpartum and the pediatric visit maybe. Training that care team in not just also culturally responsive screening, but also trauma-informed screening, understanding again that mental health is often a big driver when it comes to cardiovascular issues too. And then lastly, from a cardiovascular risk assessment, we do have to realize that optimizing cardiovascular health for individuals that have known or emerging cardiovascular disease really does need to happen, because that's most probably going to decrease the burden of any bad complications, not just in their pregnancy, but their future cardiovascular health. Who should use this toolkit? Basically everyone, healthcare clinicians and health systems, community-based organizations, policymakers and payers, advocates, and maternal health leaders. So again, please scan that QRS code below. Here are some of the resources also that really supplement them very nicely, including podcasts and some additional toolkits and some infographics that we also encourage you to share. And with that, if we do have any time, I look forward to any questions you guys may have.
Thank you so much, Dr. Bond. That was an excellent presentation. And just thank you so much for going over the 4 recommendations and the new additions to it. I think we have time for maybe one question. We have a question from the audience. And maybe from your perspective as a cardiologist, what additional training should a postpartum doula take?
So postpartum doulas and doulas in general are such a pivotal part of our care team. For those that are unfamiliar with what a doula is on this call, they're just amazing community health workers, but more so patient advocates. And I would say that one training that one can consider, and possibly an easy way to do this, would to be logging into the American Heart Association, where they often do have sites specifically in your area where they can explain to you what the warning signs of common cardiovascular conditions would look like. We do want to provide you with those tools, not, of course, to care for the patient in a clinical setting, but really to educate the patient so they understand the warning signs. Let's use preeclampsia as an example. You understanding that headaches, blurry vision, chest pressure, having right upper quadrant abdominal pain, having blood pressures over a certain number, that those are dangerous red flags that prompt them to need to go to the emergency room immediately, and of course call their OBGYN as well. So I would say working in your local areas, utilizing organizations like the American Heart Association or even your local health centers, but more importantly, your community hospitals, I have a feeling that there will be opportunities for you to understand what those warning signs look like. And then as a result of that, you would also be able to share that with the patient. And the postpartum window is such an important part for postpartum doulas because, as I mentioned, there's often a lot of gaps when it comes to how frequently they're exposed to their clinical care team. So you can help to bridge and close those gaps.
Dr. Ron, thank you so much for that presentation and that response. Coming up next at 10:50 a.m. Central, we have our third session, Designing and Implementing Multidisciplinary Postpartum Cardiovascular Care Programs. To access this session, you could return back to the lobby using the menu at the top of your screen. From the lobby, click the Sessions tab first, then the individual sessions to join. We'll also post the link to in this chat directly for you to join. Again, thank you so much, Dr. Bond, and thank you all so much for attending today's session. We'll see you in the next one.